All right, last lecture on electrical agents, right? Electrical modalities. So this will be the clinical application of electrical agents. Really, we're going to learn some of these different terms, TENS, NMES, IFC, how we use these, and how do you form a clinical decision on using these. So it's important to remember the effects of most of electrical stimulation are the direct result of depolarization of sensory nerves, motor nerves, pain nerves, and rarely muscle fibers directly. Most of the time when we hook up a patient on an electrical stimulation unit, we're trying to decrease their pain, right? Essentially, that's it. The thing with electrical stimulation units are we're changing their perception of pain, right? We're not taking away the agent or issue that is causing the pain, the source, if you will, of the pain, right? That will come more with an evaluation and better techniques as you go through the training program here at George Mason. But we can at least manipulate the machines to help decrease their pain, right? To at least start at the initial injury management or intervention or rehab portion. So basic guidelines and setup for application of electrotherapy: prepare the generator. If it's battery operated, make sure the batteries are fully charged. Clinical model, if it's not a battery operated one, make sure it's plugged into a GFI. Ground fault interrupter. Remember, this is I don't have one actually in my office here. This is the thing that most people have in their bathrooms that you plug your hair dryer in or straightener in. It might cause a surge in electricity and you have to reset the unit, right? Push the little button in. This will shut off electricity to the patient, to the generator, so the patient doesn't get electrocuted, burned. No extension cords, because that's a fire hazard. And make sure the leads aren't tangled, frayed, or broken. And ensure all buttons are at zero or in their off position. Preparation of electrodes. I very rarely see athletic trainers do this. Clean electrodes with soap and water, the gel. Dispose of electrodes when worn out and dried. Ideally, you would have a new electrode pack for every single patient, but that's not what's going to happen in the real world. These reusable electrodes are reusable, right? Hence the word reusable electrodes. You need to be cautious with them, though, because as they lose their gel, they become less sticky and can actually cause burns on that patient, right? Talk about the size of electrodes, the surface area electrode. That is why you need to be careful with those. If conductive sponges are used, moisten them with water. Connect the unit with the lead to the unit, and then connect the lead to the electrode. So lead to the unit, lead to the electrode. Make sure the patient has no contraindications. If this is the patient's first time on an electrical stim, explain the sensations that may be expected. You might feel a light tingling sensation where the stim is applied. It will feel like bugs crawling on your skin. Some patients might be apprehensive to stim. Almost every dancer I have tried to treat with stim hates it. They don't want it. They're scared of it for some reason. It's crazy. I don't know why. You determine the electrode placement technique. You clean the skin with rubbing alcohol and place electrode in an area of low hair. If you have a lot of hair in an area, the electrode pad won't stick as well. Almost nobody, right, cleans the skin beforehand, though. Ideally, you should. Determine the best technique. Is it one pad, monopolar with a dispersive pad? Is it bipolar? Is it quadripolar, 4-pad? If electrodes are not self-adhesive, you could use a Velcro or elastic wrap to keep them in place, and you begin the treatment. Monitor throughout the treatment. Make sure they're doing okay. Make sure that if your unit has a kill switch, they can hit the button for the kill switch. At the termination of treatments, most units automatically stop. If this is not the case, though, turn down the intensity and then to 0, and then remove the electrodes from the body. Why? If the unit doesn't stop automatically and it's a unit that you actually close the circuit, when you go to pick up the pad, take the pad off the patient, and the electricity is still going through the patient, you're going to get that electricity through your finger. And it's a small surface area, and it's going to hurt. We've all done it. I've done it for, on patients not thinking, doing 5, 6 different things at once. I hear a beep. I think it's that. Bam. Electricity goes through my finger. It hurts. This is actually a lab that we'll do, hopefully, when we're on campus. You remove the electrodes from the body. Wipe away any residual water or gel, which you shouldn't have any gel, right? Make sure you didn't burn the patient or have any skin irritation. And talk to them immediately following treatment to determine the effectiveness of the treatment. Did their pain go from an 8 out of 10 to a 2 out of 10? If so, awesome. Different maintenance of the unit. Daily maintenance would be clean the exterior of the housing unit, make sure the power cord and leads are neatly stored, you clean the sponges and pads. Monthly, you check lead wires for fraying, cuts, torn insulation, check power cord for the same, check rubber electrode for cracks. So the lead wires need to be checked because as you wrap them up, just like the headphones I have on now, right, as you wrap them up, sometimes they can start getting frayed. And if that's the case, that can cause some electrical issues, right? Either you can burn somebody, cause electrical fire. If you do have a frayed, cut, or torn wire, stop using that wire. If you have a backup wire, awesome. If you don't, call the company, get a replacement, and don't use that unit until you have a replacement. Annually calibration by an authorized technician. I kind of talked about that already. So high volt pulse stimulation, or HVPS, is a monophasic current. This delivers monophasic current. Makes sense. Polarity of each electrode is known. We use this for muscle re-education, nerve stimulation, and reduction of edema, and pain control. 4 different ways or reasons we would use high volt. So let me back up. You'll notice in this lecture we're going to go through a bunch of these different forms, specific forms of electrical stimulation. And it's kind of up to you to use your clinical decision-making skills and thought process to pick which one you would use and when and why, right? So muscle re-education, nerve stim, reduction of edema, and pain control. Typically produces that twin peaked, right, waveform out. 150 millivolts, or 150, volts or more is used to stimulate motor and sensory nerves. And this can actually be used as a monopolar or bipolar technique. The monopolar focuses over a wider area, and that's used more for sensory pain. Versus bipolar, we're evoking a contraction from a specific muscle. We use that more for a motor level contraction, right? So it's neuromuscular stimulation. This has a short phase duration, moderately high intensity that causes a contraction with little patient discomfort. This, in research, does not appear to translate into increased muscle strength. It does re-educate a muscle how to contract after periods of immobilization, though. Maybe the patient was in a cast and their body can't remember how to contract their hand or wrist. So we could do high volt to re-educate that muscle on how to contract. For pain control, this may be used as an adjunct treatment in controlling pain through either the sensory, the gate control, or the motor opiate level stimulation. Gate control is activated at about 100 to 150 pulses per second. This allows the body to accommodate to the stimulation. The opiate motor level stimulation is activated through high output intensity that can stimulate A beta fibers. Remember, the output intensity is what you're actually turning up the machine to, the voltage on the machine. Polarity of active electrode influences treatment effects. So if you have somebody in acute pain, this is repelled by the positive pole, right? Acid reaction. If they're in chronic pain, we actually use the negative pole. This has vasodilative properties. So in acute pain, interesting, right? We can use one form versus chronic pain, we can use another form. So what are the positive and negative poles? Almost every unit shows within the user manual what is the positive and negative pole for that unit. And what channel that is, too. That's the other thing. So gate control versus opiate for different settings. You don't necessarily need to memorize these, but you need to understand how to use these on a patient with, if you wanted to create a gate control level of pain relief or an opiate control of pain relief. So you can see output, pulse frequency, modes. I'm not going over every single specific thing here. I'm going to highlight where you place the pads directly over painful site. So maybe I have an elbow issue going on. Bam, my pain's right here. I would place it directly over the painful site. Opiate wise, I would place it directly on pain. Distal to spinal nerve, trigger point or acupuncture point. So say I have that trigger point back here. I could place that one pad right on my trigger point and a dispersive pad somewhere else if I'm trying to stimulate the opiate release. Sensory level edema control is intended to prevent or limit amount of swelling. That negative electrode, the cathode, would be over target tissues. So if I just had somebody sprain their ankle, I could put the negative electrode or the cathode over the target tissue, the ankle, the lateral ankle, right? And do that within 6 hours, and that should help prevent or limit the amount of swelling. Again, though, there's very little research out there on this. The motor level swelling reduction occurs from muscle contractions to milk the fluid out. We elicit a strong intermittent muscle contraction. This has high pulse frequency, over 100 pulses per second. It's unclear if high volt pulse stim increases local blood flow increases local blood flow. Negative polarity has been shown to dissolve blood clots, which is interesting. So I probably wouldn't necessarily use this for a blood clot. The patient would probably be on Coumadin or some kind of pharmacological blood thinning medication. So that's high volt. TENS units. You'll never hear people say the transcutaneous electrical nerve stimulator. They abbreviate that as TENS unit, right? TENS units are describes the process of altering the perception of pain through biphasic electrical current. Essentially, we're working off the gate control mechanism of pain here, big time. You can manipulate the variables for the endogenous opiate, but really it's the gate control mechanism of pain. The primary benefit of using a TENS unit is pain control. These are portable units. You can buy these on Amazon now for $20-$30. And you can manipulate less variables with them, but you can adjust the phase duration at least and try to target sensory and motor nociceptive nerves to control the patient's pain. Again, I'm not going over every single thing here, but high TENS, low TENS, and brief intense TENS, intensity, different frequencies, durations, treatment duration, how long the treatment should be on, and then the onset and duration of relief. You notice with high TENS, it takes about less than 10 minutes for pain relief to occur, low TENS 20 to 40 minutes, and then brief intense TENS for about 15 minutes. So high TENS is essentially sensory level TENS, low TENS is motor level, and brief intense is the noxious level TENS. Durations of relief, though, is interesting. Sensory level relief, minutes. It may only last 5 minutes after taking it off the patient. So why use it then, right? In my head, why would I use that if they're only going to have 5 minutes of pain relief? Can I do something else? Maybe. Maybe not. Low TENS could last for hours. Ooh, maybe I want low TENS. The noxious level stim relief usually lasts less than 30 minutes. Crazy, right? We see stim being used all the time in physical therapy and athletic training. But look, is it really making meaningful changes to that patient's pain for days, weeks, months? No. Hours of pain relief max. So the high frequency or sensory level TENS is high pulse frequency. This is essentially what I had in this chart, these next couple slides, in the chart form, which I think is way easier to read than this stuff. This activates the gate level at the spinal cord. Pain is transmitted along slow, unmyelinated, small diameter nerve fibers. So we activate the A beta fibers, causes inhibition of these A delta and C fibers within the substantia gelatinosa, blocking the pain at the T cells, right? Transmission of pain to T cells. So we're not creating a second order neuron, second order effect, right? Essentially, I put the TENS on at a sensory level. I activate the A beta fibers that override the A delta and C fibers, causing pain relief, right? Because it activates its pain and all this stuff, right? The result is in segmental analgesia within the dermatomes treated. So dermatomes, this is my C5 dermatome, C6, C7, C8, T1, right? Benefits are short-lived. Touch sensation returns to pre-treatment levels within 30 minutes. Effective in treatment of acute soft tissue injury, post-op pain, inflammatory conditions, myofascial pain, but it's short-lived. Low frequency or motor level stim, this stimulation parameters activate the small diameter motor nerve fibers, maybe C fibers, right? A beta fibers. These travel along muscle spindles. Afferent nerves activates the descending pain mechanisms. So pain relief is due to release of the beta endorphin that results in a narcotic-like pain relief. Awesome, right? So now a patient can get pain relief from this little unit instead of abusing pain medication. All right, acupuncture like TENS. We can actually put it on acupuncture mode. Some TENS units have acupuncture mode, and it creates this motor level stimulation. The pituitary gland releases acetylcholine and beta-lipotropin into blood that binds to these A-beta C fibers, blocking the transmission of pain. We could use this for swelling, muscle spasm, trigger points. Patients may actually feel better or do better with motor level stim, TENS units. Researchers are looking into long-term benefits of this, and this does involve a muscle contraction. Motor level always does have a motor level contraction. The brief intense TENS is a noxious level of stim. Pain relief is achieved by activating mechanisms in the brainstem that dampen pain impulses. This formation of a negative feedback loop within the central nervous system allows for pain relief. This activates ascending neural mechanisms. Once reaching the brain, endogenous opiates are released in the raphe nuclei. Substance P is also released, blocking the transmission of pain. This is a noxious level pain. I actually don't like this, me personally, when I've had this hooked up to myself in lab, or if I have a pain somewhere. I think it hurts, hence noxious, but it's uncomfortable feeling. I don't care for it as much. Two different types of placements here. We have a direct and contiguous placement. With a direct placement, we have 4 pads, right? Channel A or channel 1, and then channel B. So the pain, as I point to the screen, like you can see my finger at the screen. Wow. Okay. Let's go back to pen color red. Good. So the pain relief is only occurring here. So let's say this patient has pain on their upper right back. So we're only getting pain relief here and here. We're getting nothing in this huge section. But now if we do a contiguous placement and we cross the leads, that patient is getting pain relief in this whole area here, with it being centered where it meets in this area, right? Channel A, channel B. So we can manipulate the channels, make them further apart, more at an angle. We can manipulate all that. Remember, if the pads are closer together, what happens, right? They're only getting superficial pain relief or superficial relief, fibers and all that. Further apart, they're getting deeper fibers, right? NMES, Neuromuscular Electrical Stimulation. I'm going to pause this real quick. Okay, back. Okay, so NMES, Neuromuscular Electrical Stimulation, or NMES. They love their abbreviations. You'll realize in athletic training, everything gets abbreviated, even if it shouldn't, right? NMES is used for muscle reeducation, reduction of muscle spasticity, delaying atrophy, and muscle strengthening. Use of stim reverses the order in which muscle fibers are recruited into contraction. Depolarization of large type 2 fibers first. Whoop, wrong button. Neuromuscular stim provides strong stimulation than other forms of stim. Due to larger amplitude and longer phase duration, that tends to decrease the comfort level, though. It's capable of improving isometric strength. So isometric strength, here's a wall, my hand, here's my fist. I'm pushing into the wall. I'm only strengthening my right arm muscle in this plane, right? My bicep is contraction, some of my forearm muscles are, but I'm only strengthening my biceps in this angle, in this plane. And NMES does the same thing. It only increases the strength in that one specific plane of movement. Swelling reduction is similar to other forms of electrical stimulation. Use the same protocol developed for high volt pulse stimulation for NMES as well. So if you go back to the high volt slides, a couple slides ago, it's the exact same as NMES. We can have a bipolar two-pad placement over the proximal and distal ends of the muscle group. So proximal, distal. Distal means further away from your midpoint of your body, right? So my fingertip here is distal to my elbow. My elbow is more proximal than my thumb. Proximal, closer to the central part of the body, right? So if I want to place stim on my biceps here, I'll put my arm here, proximal and distal end, bam. The smaller electrode size will elicit more of a specific contraction. Remember, because size matters, right? The smaller the electrode, the more surface area, the less surface area, the stronger the electricity current is going to that pad. So smaller electrodes will increase the specific contraction. Interferential stimulation, IFC, generates two alternating currents, AC currents, on two separate channels. One channel produces a constant high frequency sine wave, don't worry about the sine wave, and the other produces a wave with a variable frequency. These two currents meet in the body to produce an interference wave, interferential, frequency from 1 to 299 hertz. We have different forms of constructive, destructive, and continuous. Allows effective stimulation of deeper tissues. We also have something called premodulated. Nice. So if you look here, I put in notes at the bottom. So when constructive, this is constructive, all right, interference, when two electrical currents are in perfect phase, that is, the wavelengths are equal. As you can tell here, the wavelengths are equal. And the phases cross the baseline at the same point, which they do, and you can see these lines are indicating that. The amplitude of the combined wave is equal to the sum of the two parts. Bam, bam, bam. So this and this equal to that. Below the baseline equals to this, back to the above and below. All right? So now if I have destructive, it's kind of the opposite. Destructive, two currents are perfectly out of phase. I should say out, not are. The positive peak of the first waveform occurs at the same point on the horizontal baseline of the negative peak of the second. What? When these two waves meet, amplitudes cancel each other out, resulting in intensity of 0. So they're opposites, essentially. This is above the baseline, that's below, right? Below, above, and vice versa. So on and so on. So it equals out to 0. Now, if we have continuous waves, two waves that have slightly different frequencies, plus or minus just 1 hertz, is just slightly different. The resulting wave alternates between constructive and destructive interference, and it looks something like this. So you can see they're just, it's very hard to see on this picture, but they're just slightly off. So what happens is we get an interferential current that way. Right, just slightly off. I think that was all, yeah. So now we can use IFC to control pain and elicit a muscle contraction. Pain control is very similar to a TENS unit. High, they call them beat frequencies with IFC of like 100 hertz, when accompanied by sensory level stim, activates the spinal gate mechanism. This inhibits transmission of noxious impulses. The high beat frequency is about 100 hertz, right? With a sensory level stimulation, so they can feel it. It's not a subsensory level. This is a sensory level. It activates the spinal gate control theory. Low beat frequencies, 2 to 10 hertz, applied at a motor level, so muscle contraction, should initiate the release of opiates, like a narcotic level pain relief. Crazy. Just by manipulating the frequency of the unit, we can get a gate control or an opiate control mechanism. So here you go. If you want to treat a patient with a gate control theory or the opiate release and how you set them up, what the parameters on the machine should be. Burst frequency for this opiate, you can do 80 to 110, you get some endorphin, versus 80 to 120, you get enkephalon. Crazy. If you click on the preset of an IFC on the machine, almost all of them are set to 80 to 150. So let's back up real quick. I don't think I've mentioned this. Why do you think when you play with the machines, you'll see all machines are set for 15 minutes? It's insurance companies. So insurance companies got with the manufacturers of these electrical modalities and set all the presets for you turn the machine on to 15 minutes because insurance will reimburse that therapist, physical therapist, right, per 15 minutes of use for that modality. So if you do 10 minutes of use of that modality, they can't get reimbursed for that. 15 minutes, though, they can. It's crazy. Insurance world. Okay. Medium beat frequencies and stim reduce edema. No good evidence on this. Don't worry about that. Next. Okay. True interferential current requires the use of quadripolar electrode arrangement. What does this mean? 4-pad. 4-pad placement. Premodulated, which you'll see in some machines, may either use bipolar or quadripolar arrangements. So for pre-mod, we're using 2 channels with 4 pads. With pre-mod, we're still using 2 channels with 4 pads, but the channel placement's a little different. We'd have to do, essentially, we'd have to do 2 different setups for the pre-mod. So channel 1 would be pad A and B, and channel 2 would be pad B and C, let's say, versus IFC would be channel 1 would be pad A only, and channel 2 would be pad B only. Does that make sense? So IFC Quadripolar Techniques, 4 electrodes positioned around the painful area. We surround the pain. Each channel runs perpendicular to each other, and they cross at a midpoint called the interference pattern. The effects branch off at a 45-degree angle in the shape of a 4-leaf clover. The tissues within this area receive the maximal treatment effect. That's why we surround the pain. Dynamic interference vectoring. So the vector pattern is rotated throughout the treatment pattern. On some units, some newer units too, you can actually, it looks like a mouse pad like on the Mac here, you can actually push and change the vector. So if I push to the left more, it would center it more towards the left, that 4-pad placement, right? That interference point, midpoint. If I go more to the upper right, it would go more to the upper right. It's pretty crazy. Yeah, so this is, and I think I actually did it right, yeah. This is an interference pattern. This has the maximal benefit from IFC, occurs at 45-degree angle from the pads. So as you can see, channel A, and B and B. B and B horizontal, channel A vertical, and at a 45-degree angle looks like a 4-leaf clover, and they're getting the benefits all throughout the treatment area with it centered on the midpoint. Now if we add a vector, we could change the midpoint to over here if we wanted to, or over here, or over here, if we had one of the mouse pad things. Then this is dynamic interferential vectoring. Yep, so we can change it. This is the picture depiction of changing it. Yep. Bipolar pads. So, yeah. When IFC is applied using bipolar placement, the mixing of 2 channels occurs within the generator rather than the tissues. Not that worried about that. So let's back up here. Russian stimulation. Russian stimulation is a form of neuromuscular reeducation, NMES. So Russian stim, if I go back here, NMES right here, Russian stim would be the preset on the machine that you would click, turn the button on, click muscle reeducation or Russian, and it would come up with this neuromuscular reeducation. I didn't talk about that earlier. Sorry about that. Iontophoresis is direct current. Introduction of ionized medication into the subcutaneous tissues using low voltage direct current. All right, so amount of medication entering tissues is based on the current density and duration of treatments. This is a reaction, ionic reaction between the positive and negative poles of the generator. Requires use of custom electrodes and medications. Medication dosage is measured in terms of milliamperes, amperes per minute. Current amperage times treatment duration. Literally every time I've used an iontophoresis unit, I've looked in the user manual for the treatment duration. Right, it's expensive to do those pads, about $100 for a pack of them. Physical therapists, as I've mentioned in other lectures, can bill out. ATs in some states can, but not every state yet. So an AT, is it cost effective to use these? Can we do something else for that? And you can see here, this picture, this is on a quadriceps. This is the delivery electrode. It looks like a car jumper cables for the car battery, right? So this one has the medication. You take the lidocaine out of this with the syringe. You douse the delivery pad with the medication. It tells you within the user manual typically how much to use, right? And then you have the dispersive or return electrode. And then this is the actual unit, and it has the directions of use. And this is a little painful because this is direct current. Remember, it goes bam, bam, above the baseline. Microcurrent, almost no literature on it, and I believe our textbook, I just got another textbook at the end of the spring semester, and microcurrent actually isn't even talked about anymore in the textbook. There's no universally accepted definition of microcurrent. It's current applied to the body that uses a direct current, monophasic or biphasic pulse at an intensity that is usually below the depolarization threshold, so it's usually subsensory stim. I have probably used this 3 or 4 times in my life, mainly because there's almost no literature out there and no good textbook way to use it. Back in the 70s and 80s and even early 90s, this was huge. Like, people use this all the time, but with very little evidence. Okay, it is up to you as a clinician to determine what and when and what mode of stim to use. What is your treatment goal? To decrease pain, it's probably a good idea to use TENS or IFC. There's a lot of information regarding treatment parameters. Do not memorize them. Learn them or you'll forget them. Please, at the end of this week, this is a lot of information on electrotherapy. If you have questions, text me, email me. We'll set up the time to FaceTime.